Hello, my name is Tammeka Evans, and I serve as the Senior Director of Global Public Health and Innovation at ViiV Healthcare. I'm really excited to share today our research related to awareness of HIV biomedical prevention for Black women in the United States. In the US, Black or African American men have the highest lifetime risk of an HIV diagnosis when you're comparing groups by race, ethnicity, and gender. However, amongst women, Black women startingly have the highest lifetime risk with 1 in 75, compared to Hispanic women, which is 1 in 287, and white women, which is 1 in 874. Further, although Black women only make up 13% of the population, they comprise more than half of all of the HIV diagnoses in the US. And as a part of that, when we look at the need for HIV prevention, specifically PrEP use, based on relative new HIV diagnoses by both gender and geographic region, the HIV PrEP use is less in women compared to men at 1.6 versus 5.7. And then in the South, when you look at geographic regions, the South is 3.0 compared to 6.4 in the West and the Midwest regions and 8.5 in the Northeast. I've shared with you several disparate statistics related to HIV incidence and with the PrEP to need ratio in the US. What I would like to share now is several strategies that we use to address these inequities through increased representation of Black women in HIV prevention trials. The first strategy is simply designing a clinical trial protocol solely focused on the population, and in this case, Black women. And then we established advisory committees heavily comprised of pharmacists and other healthcare professionals and community advocates who could speak to the clinical experience of those that they serve. Next, we communicated required diversity and inclusion and cultural awareness training for all organizations involved with the clinical trial, notably clinical research organizations. And then lastly, we targeted clinical sites with representation of clinical providers that mirrored the women who were being served in the HIV prevention clinical trial. And we're hoping that this model that we use can serve as a blueprint or a template for other biomedical clinical trials for diseases and conditions for which racial and ethnic minorities are disproportionately represented. So in summary, we identified that HIV diagnoses amongst Black women are disproportionately higher relative to the overall US female population at more than half. Black women are severely underrepresented in clinical trials relative to white women, and that we employed several strategies into the early design of a HIV prevention clinical trial to increase representation of Black women specific to HIV prevention. And then lastly, we just want to highlight that the hopes that this blueprint will help enhance and establish new networks with diverse clinical providers, specifically pharmacists who are representative of Black women in the US, and to support the objective of increased representation of this population across all biomedical HIV prevention trials. This model can really serve as a template for all other disease states where Black and Hispanic individuals are underrepresented. Thank you so much for your time.